Good morning, everyone. We hope you're enjoying the symposium thus far. Welcome to the breakout session on cannabis and cancer. This important and popular session will examine the risk and benefit of cannabis use in ongoing research. And Erin Francis is our presenter today. And thank you so much, Erin, for being here. If you have questions for Erin throughout the presentation, please use the chat feature, and we'll leave some time at the end to respond to as many as we can near the end of the session. Bit of an introduction on Erin. She completed her Bachelor of Science in Pharmacy at Dalhousie University in 2012, followed by a pharmacy residency at the Ottawa Hospital in 2013. In 2019, Erin completed a Master of Science in Epidemiology at the University of London, and throughout her career, she's been working with patients living with and receiving treatment for ovarian cancer. Currently, she's a pharmacist at Extend Pharmacy, where she provides specialized care and education to patients receiving oral cancer treatment. Erin, thank you again for being here.
You're very welcome. So I'll just share my screen here and you can let me know that everything is okay. That's coming across okay? Okay, and sound is okay? You can hear me all right? All right, so we'll get started. So just very quickly, just wanted to touch on some disclosures. So these are a few companies that I have worked with or spoken on behalf of before, but I just wanted to make everyone aware the current presentation has no industry funding and I have no relationship with companies that manufacture cannabinoids or cannabis. So this is all my own research and my own opinion. So cannabis, after alcohol, is the most widely used psychoactive substance in Canada. According to a 2017 survey, 15% of Canadians over the age of 15 years old reported using cannabis in the previous year. Its use as a medicine was first described in 1839 in India as a treatment for muscle spasms and convulsions. So interestingly, two of the things that people also claim it may have benefit for today, or that it's being studied for today. The interest in cannabis in the Western world was revived largely in the 1970s when it was found to produce euphoria. So what is cannabis? So originally the term cannabis or cannabinoid referred to the phytocannabinoids of the plant Cannabis sativa. So this is what you may hear referred to more commonly as marijuana or hashish. Today, the term cannabinoid, and in this presentation, when I use the term cannabinoid, I'm referring to all molecules that have the ability to bind to the cannabinoid receptor and their related compounds. And this includes both endogenous and synthetic cannabis. So endogenous means something that is produced within our own body. Oh, I'm sorry. What have I done here? One moment. My technology abilities are not always the greatest. 1 second here. There we are. Okay. So endogenous refers to something that is produced within our own bodies, versus synthetic is something that is man-made. So, we have both endogenous cannabinoids, or those that are produced naturally within us, and those that are synthetic, or those that are man-made that we ingest. The leaves and the flowering tops of the Cannabis sativa plant contain up to 60 to 70 different types of cannabinoids, as well as other chemical compounds. So the most common cannabinoids, and the two that probably everyone is most familiar with or have heard of before, and the two that we know the most about, are THC and CBD, or cannabidiol. So THC is the cannabinoid that we think of when we think of the psychoactive properties, or the kind of mental health or psychiatric properties of cannabis. It's what's thought to be the appetite stimulant, thought to potentially help with pain, so analgesia or anti-pain, and is responsible for being anti-nausea, or any benefit that cannabis may have with nausea. CBD is the non-psychoactive cannabinoid, and so it is more helpful for things like inflammation, or for anti-anxiety, or that calming effect that some people feel that they get from using cannabinoids. So there's something that's referred to as the entourage effect. And what this means, and this is a very kind of simplified explanation, is that marijuana is a very crude drug. It has numerous chemical components. And as I mentioned, there's 60 to 70 different cannabinoids, and many of which we don't really well understand, and we don't know exactly how they work in the body. But most cannabis products are marketed based on their THC or CBD content. There is a theory that the different components of the plant work together to create this desired effect. So even though we don't necessarily know what these other components are doing, they all work together or work in synergy to create the desired effect. And this may explain the difference that some people or some users of cannabis say that there is between the synthetic or man-made products versus when they ingest the natural plant. And there may, of course, be differences between the strains of cannabis. If you were going to a legal dispensary or an authorized dealer, they may have various strains of cannabis, and there's different ratios of these different components within the products. Just a very brief history of the endocannabinoid system. So in 1988, the first receptor, or the CB1 receptor, was discovered, and this is primarily found in our brains. Then in 1992, the first endocannabinoid was discovered. So remember, endogenous cannabinoids are those that are produced from within our own body, so naturally occurring within us. So the first one was discovered in 1992. In 1993, a second cannabinoid receptor was discovered, and this one is primarily expressed in the immune system, the CB2 receptor. In 1995, there was found to be a second endocannabinoid, 2-AG, that could bind to these receptors. So before we get into some cases, I just wanted to touch on inhaled versus ingested cannabinoids. So when cannabis or cannabinoids are inhaled, the cannabinoids pass from our lungs into our blood. Edible cannabinoids have to travel first to our stomach and then to our liver to be metabolized before they then enter the blood. Our blood carries the cannabinoids to the brain and other parts of the body to bind to the cannabinoid receptor. So the CB1 and CB2 receptors that I mentioned on the previous slide. And so remember, the CB1 largely found in the brain, and the CB2 receptor largely found in our immune system. These receptors play various roles in regulating different processes within our body. The effects of smoking or inhaling cannabis are felt within minutes and last about 2 to 4 hours. And of course, this can vary between people. Edible cannabis or cannabinoids are absorbed at a much slower rate, and they can take hours to feel the full effects of ingesting the cannabis. And in some people, these effects can last for up to 24 hours. So this is important to know if you have to operate a vehicle or operate machinery, or depending on what your occupation might be. And if you have not used these products before, that the edible formulation may be something that will stick around a little longer, and something you may need to think about. So it's hard to talk about cannabis or cannabinoids without including a picture of Justin Trudeau, because as we know, he's very much changed the way that we access, and as a result, the way we use cannabis products in Canada. So the current status in Canada is that we have prescription cannabinoids, and these are classified as controlled substances. And so these are medications that contain cannabinoids that you would get a prescription from your doctor, just like a blood pressure medication or an antibiotic, and you would fill them at a pharmacy in the form of a prescription. Then we have what you might hear referred to as medical cannabis, which is dried cannabis and oils that are legal from licensed producers with an authorization. So a medical professional will give a document that you have on hand that essentially authorizes you to possess a form of cannabis and to show that you have a medical authorization to access this from a licensed dealer, or to, in some situations, to grow it yourself. And you can also purchase cannabis from retail stores, as we know. And what is available will vary from province to province. There are also some edible and topical forms of cannabis that are legal as well. So the prescription synthetic cannabinoids that we have available, and synthetic meaning man-made, so these are medications. So these are in the form of a medication. There are 4. So Nabalone is a synthetic THC analog. Nabiximols are pure plant extract of both THC and CBD. Dronabinol is synthetic THC, and cannabidiol is extracted CBD. So you'll notice the bottom 2, the dronabinol and the cannabidiol, right now are only available in the United States. So in Canada, our 2 options for prescription synthetic cannabinoids are Nabalone or nabiximols. So I thought we would start with a case. This is Mrs. Jones. So she's a 63-year-old woman who has just received her third cycle of carboplatin and paclitaxel as first-line treatment for ovarian cancer. She took appropriate anti-nausea medications as prescribed with each cycle, but nausea continues to be a problem after each chemotherapy treatment. And I know for many of you listening, you may have received carboplatin and paclitaxel yourself, much like Mrs. Jones. And so you are familiar with the nausea medications that would have been given to her. So medications like aprepitant, dexamethasone, ondansetron, those are all medications that we use standardly to prophylax or to prevent nausea and vomiting. So Mrs. Jones has taken all of those medications as prescribed, but she's coming back for her treatment today, and she just finds that she's still feeling nauseated between her chemo cycles, and she's wondering if there's any evidence that smoking cannabis is going to help improve her nausea. So I think it's important, before I jump into the evidence to answer Mrs. Jones' question, just to very quickly touch on what we mean when we talk about the strength or the quality of evidence. And this is called the evidence pyramid. And I'm not going to spend too much time on this, only just to show that there are different types of studies. Systematic reviews and meta-analysis, you'll notice, are at the top of the pyramid. And these are essentially studies of studies. These are the highest level or the highest strength of evidence that we use when we make decisions, for recommending medications or recommending interventions in healthcare. So what I'm going to talk about today and the information I'm going to share with you largely comes from recent systematic reviews or reviews of the literature on the use of cannabinoids for treatment of medical conditions. So what does this evidence, or what do these systematic reviews say about cannabinoids for chemo-induced nausea? So the systematic reviews that are out there, they include a variety of studies of different cannabis dosage forms and formulations of cannabis. Overall, the evidence suggests that less people experienced nausea using dronabinol or Nabalone compared to a placebo, which is no treatment at all, and a similar number of people experienced nausea compared to some conventional anti-nausea medications. Most studies, though, they compare the cannabinoids to prochlorperazine or Stemetil, which many of you are probably familiar with. It's the little orange pill that we use as a backup plan when our preventative anti-nausea medications are not quite doing their job well enough. You can take a medication like Stemetil as needed to help with nausea. So most of the studies actually compared the cannabinoids to Stemetil, and they reflect chemotherapy regimens and nausea medications that were used in the 1980s and 1990s. And we have come a long way in managing nausea related to chemotherapy since then. Back in the 1980s, if you were receiving carboplatin and paclitaxel, you potentially might not have been given any medication at all to help with nausea. So you can see how discussing the benefit or studying the benefit of a medication in that context would be different than today, when we know patients are given many medications to help prevent nausea. So what does the evidence say? So cannabinoids right now are not recommended as the first option for treating chemo-related nausea and vomiting. There's no high-quality evidence, so no well-designed studies specifically evaluating smoked cannabis in the management of chemo-induced nausea and vomiting. And the studies do show that there are more adverse effects with cannabinoids compared to other anti-nausea medications that were looked at in these studies. So people were more likely to discontinue using cannabinoids versus other anti-nausea medications because of side effects. But the bottom line is that we may consider cannabinoids for patients not responding well to other anti-nausea medications. So someone like our patient today. So Nabalone is a synthetic THC, and it's approved in Canada for use in adults with chemo-induced nausea and vomiting, and can be considered for nausea not responding to standard treatment. As I mentioned previously, many of the studies looking at Nabalone and investigating its benefit were conducted more than 20 years ago. So prior to the use of standard medications that you may be familiar with, such as aprepitant, dexamethasone, and ondansetron, we do prefer Nabalone over inhaled cannabis for reasons that I'm going to discuss in a few moments. So I mentioned that in the trials, patients were more likely to discontinue using the cannabinoid compared to other nausea medications because of side effects. So some of the safety considerations or side effects that we have to think about when using cannabinoids are drowsiness or dizziness. Some people experience psychiatric or mental health effects, so they can feel hallucinations, or what people describe potentially as that feeling of feeling high. It can increase the heart rate. It can make you irritable. It can impair memory, or you may find you have trouble concentrating. And it may seem counterintuitive because we're talking about helping nausea and vomiting, but for some people, using cannabis or cannabinoids can actually cause nausea and vomiting. So for those people, stopping using cannabis is the only way to treat that. And it's important to note that the side effects that I'm talking about here are more common in products that contain THC. So a higher ratio or a higher amount of THC compared to CBD, that other cannabinoid that was more anti-anxiety or anti-inflammatory. And as always, when using any treatment for a medical condition, we need to consider the interaction that the cannabinoids might have with other medications that a patient might be taking. So this is a nice diagram that sort of summarizes, some of the things we need to think about when smoking cannabis versus taking it in oral forms or topical forms. In general, I do not recommend to patients to smoke cannabis because there are safer ways to administer. Because just like smoking cigarettes, some of these harmful compounds that are found in cigarettes can also be found when you're smoking cannabis, certainly in lower levels, but the exposure is potentially there. It's less well understood if smoking cannabis has the same potential to increase the risk of heart attack or the risk of stroke, but there is a thought that those risks are there too. And of course, when we smoke any substance, we can have an effect on the throat and the lungs. So people may experience sore throat, more coughing, more wheezing. If you're someone who has asthma or bronchitis, you may have a flare of your condition. So with other more safe alternatives to administer, I would generally recommend oral cannabis over smoking. So what would I recommend to Mrs. Jones? As I mentioned, I would advise her against smoking cannabis as there are safer and more well-studied alternatives for administration. And we could consider for her starting a low dose of Nabalone at 0.5 milligrams twice a day as needed, in addition to her existing prescriptions as a third-line option to control her nausea. I would explain to her that she may feel more tired than usual, or that she may experience some of those psychiatric symptoms that I mentioned when taking Nabalone. I will say, in my experience, for some patients that are in this situation, that other medications are not quite helping, and we do add Nabalone as sort of a next line option. For some, they do find it helpful, but I do have people come back and say that, just like in the trials, that the side effects were not desirable. Certainly, people who have children or who maybe have to concentrate at work, or are trying to perform various tasks during the day, they found it hard to function as well as they would have liked with the effects that the Nabalone may have had on them. And sometimes lowering the dose can reduce that for them. And then for some people, they sort of weigh the risk and benefit of those side effects, and they may not want to continue. Next, I'm going to switch and talk about cannabinoids and pain. So our next patient is Mrs. Smith. So she's a little further along in her journey with treatment for ovarian cancer. So she's a 40-year-old woman currently on her second line of chemo with liposomal doxorubicin for recurrent ovarian cancer. She's tolerating her chemotherapy very well, no nausea, no major issues. But her main concern today is that she has some cancer-related pain in her abdomen, for which she takes hydromorphone continuous release twice a day and hydromorphone immediately released every 4 hours as needed. She feels that her pain is not well controlled, and she does not want to increase her hydromorphone dose because she finds it makes her very sleepy, and she's worried about that becoming worse if she has to have a higher dose. So she's wondering today if using cannabinoids can help improve her pain. So cannabinoids for cancer-related pain, unfortunately, there are much fewer studies conducted on cancer-related pain compared to non-cancer-related pain conditions. So, for example, there are studies of spasticity for multiple sclerosis, some neuropathic pain conditions, and less studies on cancer-related pain. Some small studies do demonstrate a positive effect of cannabinoids for cancer pain, but overall, the evidence does not show a significant difference in the number of people who had less pain when taking cannabinoids compared to taking no treatment. There's some evidence that says cannabinoids might be effective for the treatment of non-cancer pain, and there are no studies comparing the efficacy between the different types of medicinal cannabinoids for treating pain. So what does the evidence say? So nabiximols, as I mentioned, which is earlier is the other prescription cannabinoid that we have in Canada, has larger studies than other cannabis-based products or medications for use in treating pain. It might be beneficial in treating cancer-related pain when taken in addition to opioid medications like morphine and hydromorphone. And this recommendation, it comes from the fact in many of the studies, it was studied in people who were taking those medications. So generally, it was not used as the only method of pain control all by itself. Cannabinoids might have some benefit in reducing pain caused by nerve damage or neuropathic pain. This is based on low quality studies, but I included this here today because I know neuropathic pain for people going through their journey with ovarian cancer, that's a type of pain that may be familiar to some of you because if you've received paclitaxel as your chemotherapy, you know that one of the side effects that we monitor for with paclitaxel is that neuropathy or that pins and needles type feeling that can sometimes progress to pain or numbness in people, and unfortunately can stick around when the chemo has finished, and some people have to deal with that pain chronically. So that's why I included that information here, and that it might have some benefit in reducing that type of pain. Unfortunately, there are no studies that look at the long-term use of cannabinoids for pain. So a lot of these studies are a short duration. We're not looking at years and years of taking these medications and how it affects the chronic pain long-term. So nabiximols for opioid-treated cancer patients, as I mentioned, this was the medication or the form of cannabis that had the most studies. So some studies have shown that nabiximols reduce cancer-related pain when compared to no treatment in patients with poor pain control despite taking opioids like morphine and hydromorphone. Just like Nabalone and other cannabinoids, the adverse effects of nabiximols were worse with higher doses. They might be beneficial in treating cancer-related pain when added to opioid medications like morphine and hydromorphone. Nabiximols in Canada is marketed under the brand name Sativex, and it is approved, just as I've described here, as an adjunct, which means as an add-on treatment, in adults who have advanced cancer pain who experience moderate to severe pain during their highest tolerated dose of opioid therapy. It is preferred over other formulations of cannabis, as I mentioned, because of the safety reasons, and also it does have more studies done. And it's not a pill, it's actually a spray. It's administered by spraying under the tongue or onto the side of the cheek. So what I recommend to Mrs. Smith. First, I would ask her to discuss the quality and the type of pain she's having with her doctor to see if there are other medications that may improve her pain control in addition to hydromorphone. It's difficult to recommend something to treat pain if we're not always sure what exactly is causing pain. So whenever a patient has questions about pain control, certainly my first step is to have them talk to their doctor about it, just to make sure they have an idea of what the source of the pain is or what exactly it is they want to treat. And as you know, there are lots of different pain medications out there, not just opioids. We have medications like gabapentin or pregabalin, for example, for neuropathic pain that some of you may have taken in the past. So we have a lot of different options, and I would always want to make sure we have sort of the best understanding of what is causing that pain. I would advise her against smoking cannabis as there are safer and more well-studied alternatives. And we could consider starting nabiximols at a very low dose in addition to her opioid medications. And you'll notice that in both of these cases, I recommend a low dose, and with any form of cannabis, whether it be prescription or from a legal provider with a medical authorization, the recommendation is always to start low and go slow. So to start at a low dose and see if this is effective for you, and then very gradually increase the dose if you're not having any efficacy, because if you don't know how your body is going to respond to a medication and you don't know how the side effects might impact you, it's certainly safest to start with the smallest amount and see if you can get benefit from that before going up to higher doses. And just like our previous patient, I would explain to her that she may feel more tired than usual, as well as experience some of those psychiatric symptoms when using nabiximols. So in conclusion, there's a large variation in cannabis products, and the studies evaluating their use are generally of low quality. And when I say low quality, what that means is they might be very small. They may not be blinded, which means that the patient doesn't know what treatment they're receiving. In an ideal scenario, you don't want someone to know what intervention they're receiving when they're enrolled in a trial, because that can bias their answer to questions, or it can bias how they tell you they're doing when you ask them if their pain is getting better. It may influence their answer if they know what treatment they're receiving. And it also may mean that these studies didn't have the same methodological standards or the same rigorous way that we do trials today, because maybe they were performed back in the 1980s or 1970s. So the way we do research now has certainly changed. So right now, there's currently not enough evidence to recommend cannabinoids in place of some other approved, more well-studied medications. We can consider Nabalone as an add-on treatment for reducing chemo-induced nausea and vomiting in patients not responding to standard anti-nausea medication. And I certainly have in some patients who, have not benefited from those other medications. We have tried a small dose of Nabalone. Nabiximols may be considered as treatment for nerve-related pain or cancer pain in patients who do not have adequate control with opioid medications. And it's always important to remember that cannabinoids are not without side effects and interactions with other drugs or diseases. So it's always a good idea to ask your doctor or pharmacist if it's safe for you. There are certain medical conditions that it would not necessarily be a good idea to use these products because it may actually worsen other medical conditions. And even though, there's sometimes a incorrect belief that because cannabis is from a plant, it's safe, and that is not necessarily true for everybody. So we always have to treat this just like a medication, and just weigh the risks and benefits to make sure it's best for you. So I think I'll leave it off on a quote today, which I like. It's a good summary. The discussion about medicinal cannabis is one our patients will bring to us whether we want it or not. As physicians, we should not reject cannabis as a medicine simply because it makes us uncomfortable or invokes concerns about effectiveness and safety, without acknowledging that the other drugs we might prescribe carry similar and often heavier baggage. Nor should we accede to every medicinal cannabis request as if it were an innocuous panacea. It is not. Instead, we should do what we do every day: make treatment decisions in a patient-specific context after balancing the risks and benefits of the available options. If you do that thoughtfully, prescribing cannabis will sometimes be the right thing to do. Okay, so I can take some questions now if we have some time. And if we aren't able to get through all the questions today, I'm certainly happy to take some by email after the fact, because I know you have a lot of other great presentations to get to today.
Erin, thank you so much. We're actually going to just take an extra 5 minutes for the session because it has been so well attended, and there are some questions for you. So are CBD oils or edibles traceable in the bloodstream? And would someone fail a drug test or be considered impaired as a driver if using them?
Yeah, so my understanding would be yes, that they would be traceable in the bloodstream. Now, I don't know if that would be vary from province to province. I'm just looking here because there is some recommendations in terms of which products. No, it's not going to tell me the direct answer here, but certainly impaired driving. If it was just CBD, which is, as you mentioned, or as I mentioned, not necessarily the component that gives you that same the high that people would be worried about. It's a good question. I don't know legally if a police officer or the person who would be making that call would be differentiating. It's a really good question. I can look into that for you to let you know if that would have the same implications as THC, because if it's a pure CBD oil, maybe not. But the possibility is there, I would imagine, for it to be sedating. So potentially if you were feeling sedated because you took CBD, it would not be a good idea to drive, whether it be legal or not. But yeah, that's something I'd have to look into about the legality of that.
Thanks, Erin. We'd appreciate that. And again, if you could look at that, and we can get back to the individual who asked the question. What about high doses of cannabis by vaginal suppositories to treat cancer?
I did not see any studies about vaginal suppositories as a method of administration, but as a whole, there are no studies that show that cannabis has a benefit in treating cancer. There's one study that came up in this systematic review that I looked at that treating a brain tumor, that they actually instilled cannabis into where the tumor was. But again, these are sometimes very small, and there's been no proven benefit that in humans, certainly, that this helps to treat cancer, and certainly not compared to the standard chemotherapies that you would be offered by your doctor. So it's not to say that if this was something that was of interest to you and you wanted to discuss this with your healthcare provider, certainly don't be shy to have that conversation and to pursue that conversation. But I would not recommend using cannabis in place of more well-studied treatments. And potentially, if you wanted to use cannabis, it would be alongside those more well-studied treatments.
So then the question relates to prevention and prevention in particular to a recurrence of ovarian cancer. Is there any evidence that you know of?
No, I do not. Wouldn't that be wonderful? I would love for there to be a way for cannabis to prevent the recurrence of ovarian cancer, but no, I don't know of any evidence for that. I'm just curious. The people who ask these two questions, they're so specific. Is there something that that you saw in the news or you heard that kind of prompted you to ask that question? And if you want to kind of share that after the fact, I can dig into it a little deeper. But in my research, there was nothing in my literature review that came up like that.
Thanks, Erin. And then one final, could the studies that relate to neuropathic pain be shared? I've not had any relief of this side of post-chemo.
Yeah, so there's a few, and there's a systematic review as well. I'd have to kind of pull that up separately here, but yeah, it's a really, pain is tough. Pain is a hard thing to treat, and it's very individual to different people. And I really feel for patients that neuropathic pain sticks around, because it can be really frustrating and impact your day-to-day life. So, often we try gabapentin or pregabalin first. And yeah, so if this person, would they like me to actually share, like they would like me to send them the study, I can forward that on to you, or I can forward a more recent study on to you for sure. Yep.
That would be helpful. And then just one more question, and I know, Erin, we spoke about this in terms of access. So who would you recommend be the most appropriate source for product to help with the condition?
Yeah, always I'm a pharmacist. So to me, medication that I know how to dose it is always going to be preferable. With the products that are on the market right now from a legal authorization standpoint, from a legal dispensary, in general, if you're going to use cannabis that's not prescription, certainly get it from a legal authorized dispenser, because they have standards. Health Canada has standards for how to grow the cannabis, how to produce and treat the cannabis, versus someone who may be growing it recreationally and selling it. You don't necessarily know the safety, the standards, the conditions that was grown in. So always important to be dealing with authorized dealers that are overseen by Health Canada and complying with those standards for sure. There are, depending on the province, there are dispensaries I know that are accessible. I don't have necessarily a recommendation for one dispensary over another, but I think there are some that offer a consultation, and they do have a pharmacist or a doctor that can double check that cannabis is safe with your other medications, double check your medical conditions, just to make sure you're making an informed decision. So if that is an option, for where you're going to be supplied the product, then I would choose that. And if it's not, then I would always let your community pharmacist or your doctor know that you're using cannabis, so they can let you know if they have any kind of red flags or things they want you to monitor for, because there are some medical conditions that it might not be a safe choice to use it.
Erin, thank you. This has been incredibly valuable and an important topic for so many women. So really appreciate you being here and sharing this information. We will respond to questions that were not answered today. So Erin's agreed to do some further work on our behalf. So thank you again for that. The next session as well is lunch. So if you want to grab your lunch and join us back at Feed Loop for the session, we have some entertainment for everybody to enjoy. Thank you again for being here, all of you. This was very well attended, and Erin, thanks again for your support and assistance with this information. Have a great rest of the conference.